All right, does anybody have any questions?
Yes. For the quiz?
Yes.
Can we go over question 9? Here. Mhm.
The client tells the nurse, I don't understand why God is punishing me. Is that the question? Okay. So which response is appropriate?
Yeah, that was an NCLEX question of ours, and it was the one where you said, why do you feel this way?
Mm-hmm.
And that's where we got it correct, was on NCLEX.
Okay, so I see. Okay.
So basically, I'm guessing most of us put like, what makes you think you are being punished?
Mm-hmm.
Right. Okay. Yeah,
Okay.
I'm confused about that.
I'm glad y'all said something because I wasn't the only person looking at it like, huh?
Yeah, it threw me off because I was like, well, sometimes people don't they don't have a pastor, so
Exactly.
it threw me
Exactly.
off as well.
Yep.
Because I was like, well, I thought it would be more therapeutic communication.
All right, I will fix that. I will fix that. Any other questions? Yeah, and yeah, in a way I feel the same way too, but the correct answer is like, so I'm reading the chat, sorry. Yeah, I mean, I don't know if they're all kind of, yeah. Well, all right, I will fix that. I will get that taken care of. Any other questions about the quiz? All right, so so this week's topic is hospice, death and dying, all of those palliative care type. Anybody currently working as like a CNA, an RMA, healthcare, PCA? Okay.
Yes.
All right. So what is hospice care?
Managing pain and making sure they're comfortable, more supportive for the patient and the family.
Okay. Okay. It is. And it's supportive care for the patient and the family. So it's dying with dignity is one of the biggest goals when it comes to when we provide care, in hospice. So hospice focuses on, enhancing quality of life for the patients, giving, through palliative care, supporting them, like you said, through, not just the patient, but the family as well through the dying process, providing bereavement support after the death of the client as well. And some hospice companies are really good at following up. So the most important, I'll share my screen, sorry. The most important part of hospice care is going to be pain control. Some disease processes obviously are going to be more painful than others, right? And again, it's not really even just about the patient with hospice care. It is about dealing with the patients as well, or the families as well. It's an all-inclusive What's the difference between hospice and palliative care? Anybody know?
Is palliative care
Palliative
just
care. Oh,
maintaining the quality of life? And hospice would be like if somebody is given 4 to 6 months to live, you're just maintaining their pain until the time comes for them to pass. Because I feel like they're the same thing.
In a sense, they are. Somebody else was going to say something. So with hospice, they generally have a terminal diagnosis, right? So they are, there's no cure, right? Or they have decided to end treatment for whatever reason. Okay, so we're at the point where we can offer a cure. With palliative care, they don't have they're not imminent, getting ready to die, right? We still may be using curative treatments at that point, but they just need a little bit more support, so to speak. Okay. But it is, dying with dignity is one of the biggest things that we are going to do with hospice. Has anybody ever thought about working in hospice? No, no, okay. It takes a very special person to work in hospice. I've dealt with hospice as a nurse. I've worked with hospice as a member of a family. And they are amazing nurses with what they do every single day. And I'm sure at some point, just like with anybody else in nursing, it does probably take a toll on them as well. But again, with hospice, there's no cure. We're trying to maintain as much of a quality of life for these patients as well, providing them with pain control, comfort measures, that kind of thing. And it's a comprehensive delivery system. So with hospice, it's not just the nurse, right? We have social workers, we have chaplains, and it's a comprehensive system to try to help these patients go through this process. Hospice can occur anywhere, can occur at home, it can occur in a hospital, it can occur in a hospice house, it can occur in a long-term care clinic. Generally speaking, they will have at least 6 months to live. Once all treatments are stopped. So who here has heard of the stages of grief? What are the stages of grief or the stages of death and dying, however you want to remember them?
denial, anger,
Accepting.
depression, something.
Bargaining. So what's denial?
Not acceptance of the fact that the person is going to leave.
Right. This isn't happening. There's been a mistake with the test results. I'm trying to think of what else I've heard. They need to run the test again. Maybe there was something wrong with the equipment. What about anger? Anger is pretty self-explanatory, right? People are going to be angry. You give them a terminal diagnosis, right? Anger can be directed towards the healthcare team. It can be directed towards themselves. It can be directed towards family. In some cases, they could be directed towards a higher being, right? Like, why is God doing this to me? What's bargaining?
Bargaining is when somebody tries to make a deal for more time.
Right? So, I promise to go to church every Sunday if you let me make it through this, right? Bargaining with God, just, a couple extra months, a couple extra weeks. And then depression. So after we go through the denial, we go through the anger, we go through the bargaining, we go into depression, right? And this is, I don't know if anybody has ever felt depressed or even been depressed, but it is a very lowly feeling, right? Kind of give up, don't want to do much for yourself. And, and this isn't just the client or the patient that is experiencing these stages, right? Family members are going through these stages as well. And then, of course, we have acceptance. And that doesn't mean that they're all right. It doesn't mean that they're okay. It just means that they have accepted that, that's the reality that either I'm going to pass or my loved one is going to pass. And it just becomes the new normal, right? Realize there's no way that we can change the situation. We can't go backwards, right? We can only go forwards and kind of just deal with the situation at hand. I'm sure you've talked and heard all about therapeutic communication. So, what is therapeutic communication?
Having open-ended questions to gain the trust of the patient and trying to figure out, instead of just like a why question, you want them to go deeper.
Right. So we want those open-ended questions, and it helps us to explore what is going on with our client, with our families, right? We know that those closed-ended questions, those yes or no questions, they have a place, right? If we just want a small piece of information, yes or no answer, right? Those closed-ended questions do have their purpose. Open-ended questions are going to elicit a lot more information about the needs of our client, the needs of their family. And believe it or not, that people are even at this stage, okay, when we've exhausted all of our treatment options and we're going into hospice, people are still afraid of becoming addicted to opioids. So what are some things that we can explain to our clients about opioids that will help to relieve their fears about becoming addicted to these medications?
One of my instructors put it as they don't have enough time to gain an addiction to an opioid, because they're going to pass eventually, in the next amount of time, whenever their body is done. But so there's not enough time for them to actually get physically addicted to it.
Okay, that's absolutely true. In most cases, it's not enough time for them to get addicted to it. What else?
They're in severe pain.
Right. If they're in pain, we don't want them to suffer, right? Nobody wants to suffer, even those that are not in hospice care, right? Nobody wants to suffer and live with pain. And so understanding that this is, to keep them comfortable so that they can enjoy the remaining part of their life, right? If if they're looking to spend time with family and spend time with friends, right, then that time that they're spending is going to be more enjoyable for them if they are not suffering, right? And just like with the family member, a family member doesn't want to watch their their loved ones suffer in pain, and have to remember, right, suffering instead of peace. And we use both pharmacological and non-pharmacological techniques for delivering that pain control. So we know opioids are really big for pain control. What are some non-pharmacological pain management techniques that we can use?
Deep breathing.
Okay, deep breathing. Absolutely.
Distraction.
Say that again.
A distraction.
Distraction. Absolutely.
Like stroking their hand or like a back massage or just some kind of gentle touch for them.
Okay, gentle touch. Repositioning sometimes will help too. Um, you know, I forgot what I was gonna say. Music, right? Aromatherapies can help as well. So we're going to use a combination of techniques in order to get their pain, to try to keep their pain under control. And so when we look at providing hospice care, know that heard about cultural competence. So understanding others' cultures. Now, being aware of our bias as well is super important in this and how we feel about certain things. What is the best way to learn about somebody else's culture and how that can affect their healthcare?
Research or looking at their chart.
Okay.
Ask them.
Ask them. Ask them, what are your cultural, what cultures do you identify with? What are some of your, are there any cultural needs that need to be met that we can meet, and how can we help you to meet those? And this is, something that if anybody's ever been even in the emergency room, they do this as well, right? When you go, even just to get stitches or something, they're going to ask you if there is any cultural, spiritual, religious needs that, need to be met while you're in their care. So we need to make sure that we're asking these questions. Every person is unique. And even if you were to take, a handful of people from a similar culture, right, they may have different practices. So the best way is to ask your patient, how can we meet your needs? And so we want to, again, it's individualized. So we want to ask them, never assume, never assume. Don't treat patients as you would like to be treated, as each culture can be vastly different. And so again, this is about making a conscious effort to learn about the different cultures and try to look through their eyes at the world. You're going to become familiar with the most abundant cultures in your area, right? So depending on where you live, is going to determine your exposure and your experience with different cultures. But it's always important to ask. We had a patient, this was years ago, who had come to us just for hospice care. And I don't remember. I remember that they were Middle Eastern. I don't remember from what country that they were from. And at first I thought they were Muslim, but they did tell me that they were not Muslim, and I cannot remember what religion they were. And as the mom had already been declining. She had already been in hospice care prior to coming to us for palliative care, but they didn't want mom to die at home for whatever reason. And so they brought her in. The first 2 nights that she was there, the first night she was fine. The second night I worked overnights. When I left at 6 o'clock in the morning, her respirations were 3. She was having 3 respirations per minute. And so I was for sure that by the time they came back, right, the next shift, she was not going to be there. And she was. So I asked her son, I said, okay, death is pretty imminent, right? She's going to pass soon. What should we do? What should we not do? Because he didn't want to, go against any of their wishes. And the only thing that he told me was not to shave his mom, which I was a little like, okay, that was a new one for me because I never would have thought to shave a patient after they passed. And so I wasn't sure what he was referring to until I realized that she had had some hirsutism. So I assumed it was her face that he didn't want us to shave, which I was like, okay. So I, told the CNAs after that she had passed when we went in to do postmortem care, don't do any shaving. But other than that, there wasn't any other specific guidelines. I just thought that was an interesting one and one I had never heard before. But you can do research. Like I said, the more popular cultures and ethnicities that are in your area that you're practicing, right? Those are the ones that you should research so that you can understand some of their practices. But again, always ask. That's going to be the best way for you to get the most reliable information. Other things with hospice, there are volunteers that also work with hospice. There's, chaplains. You can also, or people can also call in, their own clergy or pastors, reverends, whichever, any of their healthcare or their religious leaders to come. But it is too as well, they're going to provide some postmortem bereavement services for the family. And those services that are offered are going to be specific according to the agency that you're working with. But it's not just, the client or the patient. We're also, it's an attempt to help the family transition. And sometimes they'll stay with the family for up to a year, and kind of celebrate that first anniversary as well, of their passing. The other type of nursing that we may see is the faith community nurse. These are like your parish nurses or faith-based community nurses. They are more community oriented than community based, and obviously incorporate spirituality into their practice. They are either volunteers or they are hired by the church or the religious organization. Has anybody ever heard of a faith community nurse or a parish nurse? No. So when I was in Virginia, one of the nurses that I worked with years ago, she had gone back and she had gotten a pastoral degree, and I don't remember what it was. And she was Catholic, and she became a parish nurse through one of the Catholic churches in the area. And then she also volunteered at the hospital. So some hospitals will have either what do you call it? Either like, a couple of chaplains that are present, or they have, variety. They may have, a Catholic representative, they may have a Jewish representative like a rabbi or some other member of the church, or, a variety. Most of your chaplains are non-denominational, and they can work with a variety of different religions. But their practice is built on health education, health promotion, coordination of community resources, while incorporating spiritual and religious practices. So what's the difference between spirituality and religion? Any ideas? Can you be spiritual but not religious?
Yes.
Absolutely, right? So not everybody identifies or practices within a formal religious environment, right? Not everybody identifies as Catholic, as Baptist, as Protestant, right? They don't always identify with a formal religion, but they are spiritual. Okay, they may still believe in a higher power. And so it's different but the same, right? Um, and so with that, these faith community nurses, they are trying to encompass all of this into their care. And it's combination of that body, mind, and spirit that they are going to focus on. They provide interventions for people and groups in their home, and wherever their congregation meets, whether it's a church, a temple, wherever. They can also go into acute or long-term care facilities, through schools, and they still will fall under the the State Nurse Practice Act standards of practice. But again, their interventions are going to be based on spiritual, the physical, the emotional, as well as the social dimension. And so in order for them to practice, they have to be aware of the faith and the belief practices of the group that they are serving, right? So if they're Catholic, if they're Protestant, if they're Baptist, if they're Jewish, right? Whatever the congregation is that they are serving. So here's your spirituality versus your religion. Religion is tradition, denomination, right? So I'm a Catholic, born and raised, went to Catholic school my whole life, from the time I went to preschool till the time I graduated from high school. So very formalized religion. With we had very formalized, my family, my father's side of the family were very strict Polish Catholics. And so we went to church twice a week. Hence the reason why I also went to Catholic school my whole life. Spirituality is, it's their attitude towards that higher power. And so they still believe in a higher power, but they choose to express that in a different way and don't do the formalized religious experience. And with most people, religion and spirituality will help them through a hard time, right? And so, they rely on their higher power, whatever their higher power is, they rely on their beliefs, and they rely on that connectedness to help them through hard times. And so again, it's being open-minded, asking those open-ended questions to get as much information from them as we can, so that we can encourage that into, or incorporate that into their plan of care. And so when we look at that, why is God punishing me, right? You're right. Asking to have somebody, a clergy come isn't always going to be the best answer. But what I think what you would have to, like with my Catholic upbringing, we would see, this as potentially something that we did wrong, like this, our illness, a disease, right, is a result of something that we did wrong. I remember my mom used to say that all the time. You get sick, it's because of some wrongdoing that we had incurred or did as, prior in our lifetime. Any questions about faith, about hospice that I can answer? No. All right, so we're gonna jump into ethics and legal and ethical aspects of nursing care. So what is an ethical issue? Tell me what an ethical issue is. Are y'all this quiet always? Aisha, thanks, Aisha. Although Aisha, I have to tell you, very animated, so that kind of makes up for the quietness.
This be the last class of the week for me, and it's just like, oh, I'm so tired, so drained. But I'm paying attention, I promise.
I know, I do understand that. Trust me, I do understand that. It's Friday night, it's probably been a long week between clinicals and classes and labs and simulation. So do understand that. So let's start with something. What is ethics? What are ethics?
Like, doesn't it relate to like morals, like right and wrong?
It does relate to morals. So ethics is the rules of conduct, right? It's, is it right? Is it wrong? Right? It's not, that's the basic answer. And ethics is very closely related to values, right? And values are the worth or importance of an action that we put on something. And values are different for everybody, right? What I value is going to be different from what somebody else values, right? And our values change over time, right? What we valued younger as when we were younger, I value differently as I get older, right? So it's going to change. Making that ethical decision, the ethical decision making process can be very complex. And so it's important to understand ethical principles and ethical theories in order to make those ethical decisions. So ethics committees are there. They are mostly see ethical committees in your hospitals when we have to look at, how do I explain? Situations where we have some sort of dilemma. And ethical dilemmas are usually issues that revolve around life or death decisions. Where, let's say we have a hospice patient, okay, and they have assigned DNR and they have decided that they don't want to have any life-saving treatments. But then we have the family on the other side that are pushing for treatment and for other things to be done. So that does create an ethical dilemma for us, correct? So what do we do? So that's what these ethical committees or the ethics committees are for. And it just helps to, again, to look at the situation at hand, and kind of come to, a decision about what could be done in the situation, education, recommendations, case consultations. But ethical committees or ethics committees are going to have a set policy and procedures in place for this, in case these dilemmas do come up. And so behind all that, we have our ethical principles, and these are the most important. Your beneficence, your non-maleficence, veracity, fidelity, autonomy, justice are among the most important that you need to be able to understand. What does it mean to be, what does beneficence mean? Besides the fact that I can't say it.
So your actions do good for the person.
Right. We're gonna do good. We're gonna take a positive action to help our clients. What is non-maleficence?
Bad.
Yeah, you're gonna do harm.
Do no harm. Avoid doing any harm to our patients. What is fidelity? Not one.
Trust.
Faithfulness. Yes, trust, faithfulness, keeping promises. How many of you have worked with a client or a patient at clinical and you've said, I'll be back in a couple minutes? Nobody's ever said that to a patient? Okay. Go ahead, Casey.
Yeah, no, I was about to say I have.
Right. I think everybody has probably said it to a patient once or twice. Did you go back in a few minutes?
Yeah, because usually
Yes,
when
but
you,
sometimes you forget.
yeah, it's instances where you forget or somebody asks you to do something in the middle of it or just a number of things. But you try to
Exactly.
remember.
You've got to try to remember. So that's super important when we look at fidelity and keeping promises, right? Because when we're taking care of patients, we get busy. 100% agree with that. But if we do, the biggest thing that I can say is if we are going to tell our patient we'll be back in a few minutes, be specific. Like, I'm sorry, Mrs. Jones, I have to go do something real quick. I'll be back in 15 minutes. And 15 minutes, if you still don't have time to sit and talk to Mrs. Jones, pop your head in. Mrs. Jones, I told you I'd be back in 15 minutes. However, I'm gonna, can you give me a little bit longer? And then I will be able to give you my, undistracted time. So just those things like that. What is justice?
Fairness, treat your patient.
Treat your patient with fairness. Absolutely. What you do for one, right? We should do for, we should do similar for another. If you're, I don't even know, but making sure that we are providing the same quality care to all of our patients. We're not selective, even though Mr. Jones has been on the call bell every 2 minutes all day long, right? He still requires the same care as every other patient. What is advocacy?
Speak for your patient.
Sticking up for your patient. And what are some ways that we can be advocates for our patients?
As nurse, call the doctor. As a STNA, tell the nurse, report what you found. Yeah.
Okay. It's even something even more similar where what if you go to give a medication and that medication is incorrect, or the dosage is wrong, or something isn't right about, the order, right? Then what are we going to do? We are going to call the provider, right? What if a treatment is causing more harm than good to our patients, right? So then, we are going to advocate for them. We are seeing patients at their best and at their worst, right? And so we need to make sure that we are doing our best to advocate for our patients, to stick up for our patients, and ensure that they are getting the appropriate care and they're getting the, what they need. We look at feminist, Feminism is something that may not hear too much about, although it is something that is around. But feminism is, when we look at it's, how do I do it? Feminist ethics takes the abstract rules and the abstract principles away, and makes it more of an equality versus across the, both male and female. And so you can look at what feminists are, right? That's basically kind of what it is. It's just about equality, whether it's regarding health, all of those, and healthcare. We're just taking that away. We're making it equal across the board. What about, tell me about the Nurse Practice Act. What is the Nurse Practice Act? Has anybody heard of the Nurse Practice Act? Please tell me yes.
Yes.
So the Nurse Practice Act, what does it do?
It outlines the scope for nurses in different states.
Thank you. So it outlines your scope of practice, right? So the Nurse Practice Act tells you what you can and cannot do. Whether you're a CNA, whether you are an LPN, whether you're an RN. So that Nurse Practice Act is going to define your scope of practice. It is going to tell you what you can and cannot do. Has anybody ever looked at their Nurse Practice Act for LPNs in their state? To know what you can and what you cannot do once you become a practicing nurse. So let's see, I'm not going to call it anybody in particular, but I am going to look at where you guys are. So Ohio, is there anything in your Nurse Practice Act that stands out to you that you didn't know you could or couldn't do? Not getting anywhere. How about Virginia? Pennsylvania is not here. They're at graduation, so I can't pick on Pennsylvania. Was there anything that surprised you with your Nurse Practice Act about what you could and what you couldn't do?
Not being able to pronounce death, because like I've seen that at work where the LPN has found somebody dead, but we have to wait for our RN in the building to come and actually pronounce them. I think that's like, we can tell if somebody's alive or not.
Absolutely. And that's very true. And that's been changed. That's pretty much across the board now with all states. And it has to still be 2 nurses, right? So, and one of my LPNs came and told me that, someone had passed, then, I would go in and I would make I would pronounce. And I always had another nurse come behind me. And so that is something, you're right. Most people can tell when there is no more pulse and no more respirations, right? But that is something that is mandated through that Nurse Practice Act. And so if you've not looked at your Nurse Practice Act, my suggestion is that you do review your Nurse Practice Act can't even say it, and have a really good understanding of what your Nurse Practice Act says, so that you don't work outside of your scope of practice. Students, even as students are held to the same standard as a licensed nurse. And so, you know, a lot of people think that, well, we work under our instructor's license or we work under our preceptor's license, and that's not true. While they have the responsibility to supervise you and to know exactly what it is that you were doing, um, you know, and you're maybe a little bit slower than performing some of the other tasks. You know, once you've learned that skill, you've practiced that skill and you're performing that skill, then you are supposed to be able to, you know, to perform that skill as effectively as a nurse, even if it's a little bit as a licensed nurse, even though it may take you a little bit longer to do. And so you are responsible legally for your own actions or inactions, you know, so like if your patient's vital signs are tanking or their level of consciousness is declining or something else is going on with them, and you fail to report that, then you could be legally responsible for lack of action on your part. So, you know, whereas yes, as a licensed nurse, you do need to know your state Nurse Practice Act, but as a student, you need to know what you are able to do and what you are not able to do, in whatever degree program that you are in. And to make sure that you are not doing anything that is outside of your scope of practice while you are in, you know, a clinical experience as a student. So when we look at that, the Nurse Practice Act is overarching, right? It's going to tell you everything that you can and cannot do in that state. Your organization that you work for, whether it's a hospital, long-term care, clinic, they can minimize that, but they can't go above that, right? So for example, and I'm just going to use Melissa's example, it as an LPN, you cannot pronounce you know, a patient's death. So the organization that you are working for cannot tell you, oh, it's okay, you can pronounce. Okay, they can't do that. So they can't exceed what the Nurse Practice Act says, but they can minimize it as well. So I'm trying to think of something that would minimize, let's say, so LPNs can work with IVs, right? Just can't do those IV push medications. Well, there may be facilities where they don't want LPNs doing IVs at all. Okay. So they can minimize it. They just can't go above and beyond. And so it's really important for, and I hate to just keep harping on that, but it is important for you to know your Nurse Practice Act. The American Nurses Association is another really good resource for you. There's other, you know, they provide some general standards. They have the more broad and general in nature to apply across the United States, where some of the Nurse Practice Acts may differ. But the ANA is also another really good resource for you. And if you want, I believe the ANA also offers a discount for students should you want to join the ANA. They've got some really good resources on their sites. So just some other stuff with ethics and so knowing, you know, those ethical principles are going to be super important because then, you know, that is what's going to help you to guide your practice to make sure that you aren't going outside of your scope of practice. Who has heard of Houston? Houston is quality and safety for nursing education that is another thing that's really important. It's how we set up our nursing programs to make sure that we are including all the safety education. It's what, helps, it determines the KSAs, which are the knowledge, skills, and attitudes that nursing students need to develop in order to become effective nurses when they graduate. I forgot what I was going to say. I'm sorry. My brain just went blank. Give me 1 second. Oh my gosh. Okay, it's all right. I will get back to my train of thought in just a second. Oh my gosh. I hate when that happens. So when you are looking at, things that you are allowed to do and things that you are not allowed to do, delegation is another important aspect of what we do. And so as an LPN, who would you delegate a task to?
As TNAs or MAs.
Okay, so a CNA, an MA, a PCA, PCT, depending on where you're working, right? They all have different names: patient care assistants, patient care technicians. You could also delegate to another LPN, right? Depending on what your position is, because LPNs do hold leadership positions. I've seen LPNs as unit managers. I've seen LPNs as assistant directors of nursing. So, charge nurses. So there is a variety of, different leadership positions where you might have to delegate to somebody. What is important to know when we are delegating a task?
What
That you
that person can and
responsible.
cannot do.
The right, yeah.
What that person can and cannot do, right? So are we delegating, the right task to the right person? If we're delegating, what can we delegate and what can't we delegate? So not only in that situation is it important to understand what your Nurse Practice Act tells you that you can do, then you also need to know what the Nurse Practice Act says a CNA can do, right? Or what's the scope of practice for a care partner, or a medical assistant, right? So that we aren't giving them an assignment that is outside. And then we always make sure that the patient is stable when we are delegating, right? We don't want to give somebody an unstable patient. But who is ultimately responsible for the task after it's been delegated?
The RN, right?
If I'm the LPN and I ask the CNA to go collect vital signs on Mr. Jones, whose responsibility is it for those who's overall responsible for Mr. Jones's vital signs getting done?
Oh, the
LPN.
LPN.
The
Okay,
LPN.
me, right? Okay, just because I asked Aisha to go do it, right? And I expect the fact, respect that Aisha is going to go do it. But what if something happens? What if on the way to Mr. Jones's room, Mr. Smith calls Aisha and he is having he's, soiled, or he made him, spilt something in his room and that's a safety hazard, and Aisha has to go and help him, right? And doesn't get to Mr. Jones's vital signs, right? That's ultimately on me because I delegated that responsibility to Aisha. Not that Aisha is not going to get fussed at, right? Because she didn't do her, what she was supposed to do either. But, right, I'm ultimately responsible for that. The same thing with that Aisha can't say, okay, I'm going to go do those vital signs and then go, hey, Ashley, I need you to go get these vital signs for me. All right. So if I delegate, the delegatee cannot delegate that to another person. Okay. That is solely their responsibility. So there are certain things, right, when we have to look at, we have to kind of take into consideration. Also within that Nurse Practice Act, so everybody has heard of this compact license, right? I'm sure everybody's heard of a compact nursing license, right? And so the
No,
compact, I'm sorry,
no.
you've not heard, oh, okay. So a compact nursing license is a little bit different than just a regular state nursing license. So Ashley, you're in Pennsylvania? Or Ohio?
Ohio.
So Ohio actually recently became a compact state. They weren't always a compact state. But what it is let's say I am licensed in Ohio, okay? But I live really close to the Pennsylvania border, and it's closer for me to go work in Pennsylvania than it is to work in Ohio. Maybe I'm like, more rural, and the closest hospital is in Pennsylvania. Well, what that compact nursing license says is you can work in Pennsylvania without having to get a Pennsylvania license. All right. If your home is in Ohio, this is how your travel nurses work as well, right? So it would get super expensive if they had to get a nursing license in every single state that they are traveling to. All right, so the compact states, and I don't remember, I can tell you real quick.
Yeah, that goes against everything that I've learned from the beginning because we always got told that if you go to another state, you always have to go to that state and take you wouldn't have to like start all over, but you have to like take certain classes or certain tests to become certified in that state.
Right. And so that's the way, and that's because Ohio didn't used to be a compact state. So
Okay.
you would have to, if you went into another state, you would have to get a license in that state. So I'm going to show you. Let me share my screen.
Because that's really convenient, you know.
Mm-hmm. Absolutely. So here are the compact states. So the ones in blue are compact states. The ones are green are pending. And then the gray, there's no action. And then this purple color, which is Pennsylvania, has a partial implementation. And so someone like me, I'm originally from Brooklyn, New York. And I never would have thought New York would ever transition to compact. I think people kind of felt the same way as Ohio because it took them a while to get in. And so having a compact license is ideal for travel, right? Allows you to practice in more than half the country without paying, or obtaining additional licensure for each individual state. So let's say you wanted to be a travel nurse, right? And you're in Ohio, and you can go to any of these blue states and you can practice with your Ohio nursing license.
Is that the same thing as a multi-state?
Yep.
Because that's what they call it here in Florida, is a multi-state where you can just go whichever state you want to go to travel.
Yeah.
So we would have to take a multi-state test if we wanted to do that.
It's not a different test. So I'll clarify that for you too. Oops. Did I share my screen?
Yes, ma'am.
Okay. I was wanting to make sure because I was like, were y'all looking at oh, I can't. I was like, no wonder because the share button went onto the other screen. It is not a different test.
Right.
It is the NCLEX is a national exam. So whether you live in Florida, Alaska, Hawaii, or Vermont, or any of the other states in between, it is all the same exam. So if your testing is the LPN, doesn't matter what sate you take your LPN exam in, it's the same. Same thing for RN.
I think it just the cost of the test is different. Like it's more expensive because that's what they told us. there's a lot of LPNs in our state through Fortis that got multi-state, and the test was like $150 more to do a multi-state.
Maybe the licensure, not the test.
That's what I was getting ready to say. It costs more for the license, but not the test itself. You have to pay more for a multi-state license.
Exactly, but not the exam. The NCLEX is
Okay.
$200 regardless of what state that you live in.
Okay.
But the cost of licensure, so your application through the Board of Nursing, it may be more expensive to get the compact license. That I can't attest to. Because each state's Board of Nursing is responsible for, setting those fees and all of that stuff. So I can attest to that. But yeah, and then once you have it, the biggest thing too, though, is just because you get that compact license or the multi-state license, whatever state you're practicing in, you still have to know what's in that Nurse Practice Act. Okay, so like I said, if someone lives in Ohio and they decide to practice in Pennsylvania or Illinois or wherever, West Virginia, they have to know what the Nurse Practice Act for that state is so that they don't violate. That is something that is super important, because while most of the states have the same do's and don'ts, there might be little variations. And I don't know all of them, and I will never know all of them. But like, I can use the CNA as an example because I also used to run a CNA program, and this I always thought was really interesting to me. So it always stayed in my head. In Virginia, CNAs can't do tube feedings, right? They can't do bolus feedings, they can't do continuous feedings or anything like that. But in some states, CNAs can do tube feedings. And I thought that was really interesting. And so when I used to teach in the LPN program, I always brought that up when we would start talking about delegation.
Yeah, here in Florida, like we have PCTs in the hospital, and they can do the vitals, but they cannot measure urine output.
Okay,
And I don't understand that, because you're measuring a vital sign and then you're looking at a number on a catheter bag. So what's
right.
the difference in?
That's very interesting. That is interesting. I can't even answer that. I can't answer it. When I was in Florida, I was a home health aide. I wasn't a CNA, or a PCT, so I'm not sure. But that is interesting yeah, because in most states.
I mean, maybe it's because
too,
it's bodily fluids and you're measuring, like, the nurses know how much they're inputting and then they need to know the output. I don't know, but I just thought it was weird being in clinical and seeing a PCT say, well, I can't measure that.
Yeah.
I can do the vitals, but I cannot do anything to do with the catheter.
That is interesting. So yeah, I know that the PCTs in Virginia, they can do vitals and stuff like that, or catheters and stuff like that. So that's pretty interesting. And then, so yeah, so
maybe it's just the facilities too. I mean, I don't know. They
Well,
just
that
at the
could be
hospital where
too.
we were at, just they were not allowed to do that. And then there's some floors where PCTs, CNAs are not even allowed on the floor. Like they don't have any of them on the floor.
Right. And a lot of times you'll see that in like ICU, they won't have certain floors won't. It's just interesting, and that's going to be state specific, right? So that is very interesting.
Yeah, LPNs here in Florida, we like there's rarely any jobs at the hospital anymore.
Has that changed recently? Because
Yeah, we're doing all of
now,
our clinicals at the hospital and there is no jobs. They're switching everything to RNs. You're either a PCT or an RN, but we don't do any clinicals in a doctor's office.
wow. Because most places you see the opposite. We are starting to see more LPNs being hired in the hospitals. Wow. That's pretty interesting. It's funny how each state is different. With so when I moved here and I just kind of got a feel for, what's around, talk about like the nursing shortage and, what are the as we move forward, what do we need for nurses? I moved to the one state that is going to actually have an abundance of nurses. So if you need a nursing job after you graduate, don't come to Texas because there are no jobs here.
Yeah, just a couple of years ago, they passed a law that RNs are no longer allowed to intubate, do any of that. It has to be respiratory therapist or MDs.
So in most cases, an RN would have to have a special certification in order to intubate.
They're not allowed at all.
Wow, that's interesting. I don't know. Florida sounds Florida's been through a lot, so I'm gonna give Florida a break. And they've been through a lot in Florida. So
Yeah, we can't even do anything like communities class for us is like null and void because we can't work in the jails, we can't work in the schools, we can't work at the health departments, none of that.
So what are y'all supposed to do? I'm
Yeah.
sorry, but what are y'all supposed to do?
I'm not even going to respond to that because we're on a recording and it goes to the federal government. So
It does not.
I'm just going to do this with my thumb and I'm going to let you read in between the lines.
Oh my goodness. Wow. So yes,
So most of us are getting what we call a multi-state license because, economy, everybody knows the economy, it sucks right now. And working in a doctor's office, you're really not getting experience for what you're trained to do. And we're not doing any clinicals there. And then at the nursing homes, that's about the only place you can go, but they have no job openings unless you want to be a CNA with an LPN license.
Wow.
So most of us are getting a multi-state license and getting IB certified just so we can go to Alabama and work because you're not allowed on most med surge floors. No. Maternity, absolutely not. Peds, absolutely not. None of that. They're weaning out the LPNs down here in the hospital.